Can you hear? Can you hear? No.
You might have to speak up a bit.
Can you hear?
Yes.
Right.
Yeah.
Okay. Just in the distance, right?
So we're just going to do what we've called a talking heads, and we're going to try and highlight some of the concerns that people with mental health problems and their carers have in negotiating the healthcare system. I'm sorry if people on that table can't see us. If you want to move, that's fine. If you just want to listen and enjoy, that's fine. We are going to attempt to live stream this, and we're going to try and stick to the point. So I hope we can manage that. So, can I introduce David Shiers?
Hi, I'm David Shiers, old GP and a carer.
And David Lee.
Hi, I'm David Lee, a patient long term with mental problems and physical problems, which take priority, I don't know.
Okay, so this is a question. It's going to be confusing because we've got two Davids, so I'm going to say David S and David Lee. So I'm sorry that that seems a bit impersonal. So question to David S. I want you to tell me if you can, and tell us if you can, why closing the gap is so personal to you.
Okay, well I've got two perspectives. One is as a father of a daughter who's now in her 40s, who was given a diagnosis of schizophrenia when she was 16, and also as a carer. But first, from my daughter's perspective, Mary wouldn't really have a voice. So I think I'm here partly as a voice for people like Mary. She's in her 40s, has brothers also in their 40s. Mary's got 5 conditions and takes 11 pills and sees several doctors and has a blood test every month. And her brothers don't have any of that at all. So that, and Mary wouldn't be here being able to say how she feels about this, but she, I think, would be pleased that this is being discussed. And it really picks up Neil's point, isn't it, about the complexities that people really live with. And then the other side of it is, as a carer, I had an interesting email conversation with Andre about a week ago, and I was describing some of the personal challenges. I've been a caregiver for 26 years, so some of the personal challenges. And Andre concluded that that I was a difficult carer, and that it's a shame because the system seems to pit us against each other. And actually, I thought about that, and I thought, I'm not sure. I think maybe being a difficult carer is okay. I don't, and maybe that's something that would be helpful to a collaboration like Closing the Gap. So that's just a thought. I'm not sure that being a not difficult carer would be that helpful. Okay. So I wasn't always a difficult carer. The first few years, I was a despairing carer, really. I'd seen my daughter very young, first 12 months with a CAM service, who was a weekly meds discussion, and we were given really no other support, and then Mary became iller, and we were reassured by the psychiatrist, who was a good psychiatrist, saying that, well, if you can just hang on till the adult service, they're more into psychosis. But then when Mary eventually went into the adult service, just 17, this was a very chaotic, acute system, quite close to North Staffordshire, so it's not far from here. We realised that they might be into psychosis, but they certainly went into young people. And then 6 months of that, and Mary went into the asylum. She went in for rehabilitation, to the rehabilitation ward at St Edward's, which was in my practice area as a GP. And that was, so this was a couple of years, so I was beginning to doubt progress. Mary wasn't making progress. She had an unremitting psychosis for, by that time, 2 years. New psychiatrist started in that rehab service called Fiona Macmillan, who would be known to this trust, actually. But Fiona was quite rebellious psychiatrist, and Fiona brought my wife and I into her room 3 days after Mary was admitted and said, I think you should complain about the care I'm giving your daughter. And the other thing that Fiona did was she said, I think Mary may benefit from clozapine because we've tried most other things and nothing else has happened. So Mary started clozapine. So what I actually saw with Mary then, thinking about Mary's physical health, was that she didn't do anything at all. She just sat around. She was very sedated. She was slumped in a chair most of the time. People felt sorry for her. The one thing Mary had was a craving for food, which I think was related to the medicines mainly. And so she ate. And the staff used to give her extra helpings of puddings because they thought there was no other enjoyment for Mary other than eating. So we saw Mary's weight go from 9 stone to 13.5 stone, and Mary hated that. That was made her different from her friends. And one thing she didn't do was she didn't acquire the smoking habit that was everywhere. So elderly men smoking in corridors was a vivid memory of that old asylum. So essentially Mary had been fattened and flattened by NHS care in the mid-90s. Fiona had also, apart from starting the closet, also suggested we complain about her care, as I said. And that complaint is quite relevant to actually physically being here. We'd had 6 months of getting nowhere with the local senior health managers, and in fact, and then I discovered that if you sent a letter higher up the chain to the region, we had an amazingly quick response, and the local health authority rapidly asked us to come and attend a meeting where we were told off, really. We explained that what more could they want? They were giving Mary a bed. What else? It's really social care's problem. And at the same time, the mental health lead for the region visited our home, rang up within days and said, "Can I come and see you?" Came in, said within 10 minutes, saying, "I'll do what I can to help Mary, this isn't right." And the second thing he said was, "Do you fancy forming a small group to improve services for people like your daughter in the West Midlands?" So we actually physically met 50 yards from here. I walked past the building today, 24 years ago. Fiona and myself and Anthony Sheehan and Max Birchwood and Joseph, and we had this wacky idea called early intervention. And so I was stopped and became, I was officially then an awkward carer, contributed to a group which I felt slightly out of my depth with. And we got involved then in policy development. And I gave up my job as a GP. The closing of that programme in 2010 was for me unfinished business for the physical health. So in a sense, being here today as a complaining or difficult carer, I hope there's some ability to collaborate in this network to do this sort of unfinished business of people's physical health.
Thank you. I think your reflections are really important, and I think we always talk about carers as advocates, but actually being an advocate sometimes means you have to be difficult to create a stir. Thank you, David. So, David L. And I'd like you, if you can, just to tell us about the difficulties you've already alluded to of having mental health problems and physical health problems, some of which might be related, and the sort of burden of getting care for both.
Yes, they reflect some of the things David has said, but from the other side, if you like, as a sort of habitual ill person, I have bipolar. I would say probably all my life. Got involved with psychiatry at the age of 8. My first appointment, and I can remember it, but a lot has changed in those years. We're looking at 60 years ago, and attitudes to mental health have changed quite dramatically in the professional life, but in public life it's got worse in a way. There's more separation, that people think, a lot more problems with the younger people as well. Mine, I have prescribing, but my first sort of major illness, physical illness, was misdiagnosed initially, and I was told I had an illness which was a respiratory illness. In fact, I had sarcoidosis, which is fairly rare, and but I was virtually at the point of I collapsed, and although I was running my own business at the time, and it was a misdiagnosis. I think it was rheumatoid arthritis. The local GP had me down as. So I had to pack up. I had a young family, back up in Northumberland and moved to my parents in Hampshire. And their medic, their local GP, saw me, and within 2 or 3 hours I was in hospital. And it was sarcoidosis, which is difficult to interpret, I know. But then, of course, bear in mind my whole life has sort of been high and low. So they give me steroids as being the only thing that they knew dealt or suppressed sarcoid. I had pulmonary sarcoid, so I could hardly breathe. I couldn't walk virtually. So the physical side, it was then exacerbated by taking steroids. Steroids, you have amazing highs. And I was on high doses of steroids. I'm a designer by trade, and in fact it was, in one sense, brilliant, because when I had highs, I was flying and incredibly creative. I did some of my best work in my life. But the price physically I was paying was extraordinary in all sorts of ways. So that went into remission after about 15 years, 20 years. And I eventually stopped taking steroids. Steroids are incredibly difficult to get off. They are very addictive. And you try many times to come off, but you fail in the last bit of the race, and it all goes topsy-turvy. Then, incidental almost illness, I had cancer. Thankfully, that is in remission, I believe it's the term, as is the sarcoid. But the latest illness, which you can't get until you're in your 50s, is late onset muscular dystrophy. I have IBM. It's fairly rare in the canon. It basically means that your muscles are vanishing. Their effectiveness is diminishing. And you end up with a cocktail of drugs. I've got cocktail drugs, some make you feel good, some people push you down, some make you feel hungry. And I think, as David said, with his daughter, you resort to what I call comfort food, and you inevitably put weight on. But the other thing is, you become, with bipolar, you can have quite lengthy reclusive periods of depression, where you don't leave the house almost earlier, and it doesn't suddenly get better because you're being given drugs and things. And since I was David, I take 10 different drugs every day to keep stable. But that, I have noticed that when you're being dealt with by physical health, your GP, they're not always, they don't know enough about mental illnesses or how you have relapses, you come back. You know, I cannot tell you what I'll be like tomorrow. I have no idea. I could be fine, as I am today, or I could be not leave the bed virtually. And try to do exercise regimes. I'm under a physiotherapist for the IBM, and I go to the GP who has a weight clinic, and I go every week to that. But I wouldn't say it's easy.
Thank you so much for sharing that, and I think what you've illustrated is that the complexity and intertwining of the mental and physical, but also the diagnostic overshadowing. So
Yeah.
some of your symptoms could be put down to mental health problems
Yes.
because you've got that label in your notes.
That's right. They're always looking for the wrong thing
Yeah.
half the time.
Thank you. Swap microphones, thank you. So, David S., I want you to, if you can, just give us a couple of examples of the challenges, and you've already alluded to these, but other challenges that Mary faced in terms of her physical health.
Okay. There was a moment when Mary was taking 900 milligrams of clozapine, the big dose of clozapine. She was, as I said, in a very poor state, and I challenged it was actually a mental health nurse who was this was the conversation with is it possible that Mary could reduce her medicine just time that she was drooling? The big problem was she was drooling all the time. She just couldn't go out. She was just wet through all the time. And we so in the end we negotiated for a 25 milligram reduction, you know, not a great deal. And the nurse was not keen. She said, well, she's fine. You know, why are you trying to reduce her dose? And it was a difficult conversation because Mary had a very severe, unremitting psychosis. However, her quality of life was pretty zilch. And the one thing Mary never lost was the desire to go shopping. So to be constantly wet through and unable to, you know, was difficult. So 25 milligram reduction, I had no idea, but she stopped drooling. She also woke up a little bit. She now takes 200 milligrams. That's over 15 years. So the sense about the medicine, so, you know, I think clozapine from a research point of view is fascinating. Mary took 3 years to get onto clozapine. It happened to work well for her. But she was so late in getting onto it, she was taking massive doses. Then the negotiation, you know, the priority was not physical health. The priority was not Mary getting out shopping. The priority was somehow stopping the psychosis coming back. Fair point. But just to illustrate the power of actually, and being an awkward carer, I think was really quite critical to that, being a difficult carer. Another thought, just thinking about that, so I'm having a look at, that's from a specialist point of view. From a primary care point of view, when I was, shortly after I was made redundant from the physical health, from the early intervention programme, I said to my daughter, who was a practice nurse, do you fancy a session on physical health? I still had this sort of burning unease about physical health. So this was about 2012. David's a good practice nurse locally, and she had 25 nurse colleagues say, yeah, that'd be great. Half a day session, I was free, and they were all geared to do it. And then the practice managers turned around and said, well, it's not core business. And actually, that was one of the most galvanising moments in my recent life, was that, well, it is bloody core business. And this wasn't the practice managers. This was general practice. This was GPs actually, not regarding it as core business. So I felt, you know, so that's just to illustrate what Mary's facing. And Mary requires really complex care, real precision care, and it requires, and she has good general practice care and good specialist care. But that primary care, seeing it as not core business, troubles me.
So hence the need for a
We
special
definitely
interest
did. Yes, I think so.
So, David, can I ask you how you got involved in the Closing the Gap network?
One of the things I've found with having bipolar is that you can be very enthusiastic and almost get over bubbly about something. And I've always had an interest in knowing what my illness is, trying to find out, and found it very difficult to find out information. And I then joined a group which then met in Shrewsbury, based on our, what were then CMHTs, but they no longer exist under that title. But my nurse does, so she's still seeing me. And I got involved in that in Shrewsbury, which was looking at health issues right away across. I found that very interesting, and then I got involved here with Tim Lewington, and eventually we set up PACE-R, which is patient and carer expertise research. In other words, taking the fact that patients have an awful lot of expertise, which never comes to the surface. If anything, it is contradicted by your discussions with consultants and things. I got involved in this because Caroline came and gave a presentation on CTG back in last June, I believe it was, and to the PACE group. And I thought then it was a good idea, you know, the idea of trying to close those two disciplines, which almost starts in the educating of healthcare people. So the split is very early. And yeah, they're complex things, all of these illnesses and that. Then that presentation is smart things, and then I was invited to go to the other end of the country, to York University, on the first meeting, I think it was, on looking at how you would respond to certain issues in the publicity of those things, and what were the benefits of CTG. That was very interesting, and I do like to be involved. In that respect, I've become a patient ambassador in research locally. although we're now called champions, I believe, but I don't feel like a champion. So I'm very interested to get involved in these things because I think that is the only way we're going to find a way forward. Because at the sharp end, we're the guys who's got the problems.
Thank you. So David, I'm aware we're running out of time, so I want to recognise the fact you've been a tireless advocate or a difficult carer for some years, but what do you think has been achieved so far?
Well, the early intervention wacky idea I think has been an interesting one. So I think that's achieved quite a lot for people. So if one of my family went in with an acute psychosis today, I don't think they'd experience what Mary had. I think they'd go into a much more community-based service and they'd get proactive care. Their families would be supported and they wouldn't just get meds. And less likely to get admissions. But the body and mind stuff, so I think the keeping the body and mind idea, that you know, Mary's problems were so palpably there right at the very onset of this illness. And yet, you know, Mary's now in her 40s, the same age as the Stepwise programme that recently published on weight management, Scimitar, in terms of an effective approach for smoking. But I look back at what Mary was experiencing right at the beginning of that illness, I'm thinking the irresistibility of that trajectory, that if you can interrupt that trajectory, and I don't think it's just for cardiovascular disease, so I celebrate the fact that the early intervention has got some traction. I think I stand today with more than 5 other colleagues thinking that there's a real challenge for people's physical health, but I think there's an opportunity for early intervention. I think actually tackling these determinants. This wasn't Mary's lifestyle choice. You know, what I described was not lifestyle choice. This was Mary put into a situation which she shouldn't have been in. And the opportunities to, you know, Mary was a walker, she rode ponies, terribly dangerous animals. All of that stopped. All of those things that were part of who this person was lost. And she lost all that. And it's very difficult to bring that back. So this concept of where do we go next, I think this early intervention aspect is really critical to this gap. Yeah.
So not just early intervention in psychosis, but early intervention.
Right from the start, keeping your body in mind right from the start.
And there are quite a lot of resources,
I have
some
brought a
of
few
which
things.
David has put on your table.
Keeping the body in mind right from the start is the clues in the name, really, isn't it? Yeah.
David, what do you think the ambitions or the priorities for closing the gap should be?
I think there's so much importance to be placed on looking at patients in a different way, and it is a mix of the two disciplines, physical and mental, and I hope that Closing the Gap's going to do that. We're setting programs which are realistic and constant. I think the thing when you have mental issues is confidence in yourself, because it's so variable, and confidence in the system. And if the system isn't talking to you, you're very lonely. And I rely totally on my carer and my wife. I'm 50 years now, and I don't know how she's put up with me, because if she hadn't been there, I wouldn't be here. And therefore, care, if you're fortunate, is with your wife or your family. But for a lot of people, they're alone. They have none of that. And that's where this Closing the Gap can help a great deal, by educating both the people that deal with you and yourself. Because the more you know about the illness that you've got, the more you can compensate. You can work around it. I always call it for workarounds. You know, if I'm really down, I know how to gradually get myself out of that. And it does work. But there's nobody to guide you. There's nobody to tell you. It's very much your own thing. Just a recent experience of where Closing the Gap would perhaps help was I suffered greatly from pain. I was on very high doses of morphine and fentanyl. And I then went to a pain clinic, but it was a one-to-one pain clinic. And that worked. 30% is their success rate. It took 10 months to come down from 60 ml per day of morphine and fentanyl patches. It took 10 months to get me back, but I learned so much. I changed my life totally, which is what we needed. and my whole way I live and everything has changed and made a huge difference to the way I live. I feel I have a life and I enjoy it, whereas before I was just rolling along, sometimes lively, too lively, and other times morose and a big pain to everybody.
Thank you, and thank you for sharing that very personal information. I want to finish on a high note. I'm going to get up and put a slider. And while I put the slider, David's going to talk about how Mary is now.
Right, okay. So I thought, I don't want to give you the impression that Mary's done badly, in a sense. Mary's great pride to our family. This is her 40th birthday, which is a couple of years ago now. And stretched limo and family and friends and little grandkids. And you can see that Mary can shop for England, and she's incredibly resilient. You think back, and I think back to what Mary experienced, and then the resilience. I think one of the biggest challenges was not taking on the inherent pessimism in the services around us. And so I think there's a pessimism-hope thing is really critical. So we never quite bought it. We almost bought into this idea of Kreplin and pessimism. This will end up, with permanent long-term care. But actually, Mary's in a beautifully supported residential care where the care is superb. It's so precise. It's so complicated, actually. And this is a very underpaid part of the system. But they are fantastic. And we've got, as a family, we've got complete faith in the system that she's in. And she does take only 200 milligrams of clozapine now. And that's quite important. And she is able to indulge. I suppose the other thing is that you have to have a life. Mary has to have. She has a purpose. So all the things you might talk about in terms of giving people support for physical health and mental health are as nothing if you haven't got a purpose for getting up. And I think that's perhaps one of the clearest messages. And also families. You do need to think about families. And maybe that's something we should think about in closing the gap too, that the health of this group, the health of families, is quite seriously affected by the strains of supporting this sort of condition. So listen, she's doing okay.
So finishing on a positive note,
Absolutely.
just to say thank you to David and David very much for sharing your very personal accounts and thoughts and reflections. Thank you. Can we all put our hands together?